Good afternoon, dear colleagues. Let me present the progress of my PhD work so far. This is about the effects of materials and prosthetic design on the peri-implant tissues. I am from the Department of Prosthodontics, and my vision is to provide the best treatment possible for my patients. And for that, I would like to implement a fully digital workflow in every aspect of the implant rehabilitation. I have these two specific goals. The first one is about two restoration materials. The second one is about two different prosthetic designs and their influence on the tissues. The first one is comparing two restoration material. One is zirconia and the other one is metal ceramic. For many years now in dental restoration, the gold standard material has been metal ceramics. This is no surprise because they have an excellent survival rate over 5 years. Later, as digital technologies, namely CAD/CAM technology, evolved in dentistry as well, other ceramic materials showed up. One is veneered zirconia. These two restoration types work as a framework, and they need to be veneered with some kind of other ceramic. The major problem with these veneering ceramics is the relatively high chipping rate as a technical complication. This could affect the function and the aesthetics of the restorations as well. So in order to minimize these complications, new material showed up. This is monolithic or full contour zirconia without the veneering ceramics. They have excellent biological effects because of the low plaque accumulation rate, the low bleeding index, positive effects of cell adhesion. They also have promising aesthetics, mainly in the posterior region, and because of the ability for CAD/CAM processing, they have also high accuracy as well. There are results following monolithic zirconia, but there is no comparison with the gold standard material, whether it can be a good alternative one. So therefore our aim is to investigate its benefits comparing with the metal ceramic crowns. Our question is how monolithic zirconia crowns perform in comparison with the metal ceramic crowns. Our hypothesis is that monolithic zirconia restorations can be a valid alternative to metal ceramics. After the selection process, we've got 4 eligible RCT articles, and our first result is marginal bone loss. This is important because bone gives the stability of the implant, thus indicates us the success of the implant. This is measured by millimeters, and we can see that the mean difference is minus 0.11. This means that in the investigation group, we've got 0.11 less bone loss. However, this is not relevant, this is not significant clinically nor statistically. The next one is bleeding occurrences. Here we can see that the odds ratio is 0.66. This means that in the investigation group, there was approximately 1/3 less bleeding, or the odds for bleeding was 33% less. The third result is chipping occurrences. In the first analysis, we included all eligible data, and here we cannot see a significant difference, but we can see a tendency favoring monolithic zirconia. In the second analysis, we excluded a patient with bruxism, and here we can see a significant difference between the two groups favoring monolithic zirconia. The last outcome was implant failure occurrences. Here we can see that the two groups resulted almost the same. This indicates or suggests that restoration material may not have an effect on the implant success and failure. For the conclusion, we can say that at 1 year follow-up period, both restoration types were similar regarding the bone loss, the bleeding and the implant survival. However, monolithic zirconia crowns presented significantly less chipping over 1 year. So we can say that these crowns are valid alternative options besides the golden standard. Our strengths are that all of our included studies were RCTs. There is no other meta-analysis in this topic, and we had low statistical heterogeneity. However, the limitations are the low number of studies with short-term follow-up periods, unfortunately, and there were some heterogeneity among the included patients. Implication for practice is that using this material would mean more predictable and effective restorations because of the CAD/CAM technology. It would mean also quicker production and more cost-effective manufacturing. Also, soft tissue adaptation may be better, as some studies say. Implication for research: we need more studies, of course, with medium and long-term follow-up periods. And studies should involve biological outcomes, more detailed inclusion criteria, and more homogeneous populations regarding bruxism, the retention types, or implant types. The status of this manuscript was just rejected yesterday, so we are heading toward the next journal. The second topic is the influence of different prosthetic designs on the peri-implant tissues. So the hard and soft tissue stability is crucial because this indicates the long-term success of the implants. After the implantation, supracrustal tissue attachment needs to form around the implants. And therefore, bone loss has to be taken place. And this bone loss, marginal bone loss, also indicates the long-term implant success. This marginal bone loss can be influenced by many factors, as you can see. And from these, we are interested in the abutment height. It can be short or long, and studies are controversial regarding this, whether short or long are better, preserving more bone. So we would like to investigate the influence of abutment height on the crestal bone stability. Our hypothesis is that the long abutment height may preserve more bone. This would this would determine the best abutment height to use, preserving more bone and more stable tissues. We've done the selection and we have got 7 eligible articles. The progress of this project is currently under statistical analysis. For the summary, we would like to finish the second project in September and then start a clinical trial as well. And thank you for your attention.
Thank you for the presentation. You have amazing progress. I have a question about your first topic, that you suggested that research should focus on medium to long-term follow-up. And I want to ask, I don't know anything about these materials. Why does it make sense to have a 5-year follow-up instead of 1 year? And doesn't it make more sense, or 10 or 3 or 8 years? Why 5?
1 year is a relatively short follow-up, and over 5 years, more technical complications can occur, and with a 5-year follow-up period, we can get a more comprehensive look on the material.
But do you have any guideline, not 6 years or 4 years or 2 years? Does it make sense for these materials?
Most of the studies in this field are searching for this 5-year period, yes. So that's why.
Thank you.
About your second study, I wonder what is the internal control for short and long abutment, because every single implant is an individual case. How can you compare short and long abutments?
These short and long groups contains a range of abutments, so not a one specific length, but
no. I'm not interested in the length of the abutment.
Yes.
I'm interested how can you compare, because there is an implant and there are other individual implants, and you use one length at case A and then B and C, but all of them are very different. Left or right, which one is the dominant side of the patient, what is the load of the implants. So in my opinion, you can compare them if you use the implant twice. Absolutely the same environment, and you put in a short one, and you should start the whole case again, and you should use a longer one. So how can you compare two different implants?
Yes, absolutely right, thank you. So interestingly, there are studies comparing these two abutments with each other. They are using short abutments in the one group and using the long abutments in other group, and sometimes irrespectively the tissue length or vertical tissue. There are many limitations, we know, but we think that there are enough studies to make an analysis of this.
So all those papers which you have selected are using different lengths of these abutments, but no control side or no control patient, or what is the control patient if you are using a long one instead of short one?
Yes, there is no control patient, just comparing the two groups. So there is a short group with 0 to or 1 to 2 millimeter height, and there is a long group above 2 millimeters height.
So it's any other questions?
So my question is about the same study. What is the reason behind your hypothesis? So you hypothesize that the longer one is better, but why?
Because most or more studies said that longer abutment have less bone resorption, so that's why I could hypothesize this.